Hi, everybody. Can you all see me? Yeah, I think looks fine. So we had this lecture last week, and we decided that, initially I was planning to go from head to toe for the scenario and to kind of cover everything from the beginning. But I realized that uh, people are not really uh, exposed to IR. So I discussed with Dr. Zainab as well, and as per your request, we've gone back towards starting from basic things, and then we'll build it up from there. So we'll go from disease to disease, but initially we'll start from non-vascular first, because I think that is something at the UG level you will have to do, perhaps not only just learn about it or give it in your exam or write about it in your exam, but overall also you need to be able to do these things. So I have brought a few, needles and, biopsy guns, because that is the primary intention of this class, that we'll be focusing on FNAC and biopsy. So anybody, who's been doing a bit of work, you are feel free to send in your questions in between. I will try to take them whatever I can, and also you are free to, send your questions later in the Telegram group. You can even share some cases which you are, planning, you want to do, you want to know, and something that can be done. And apart from what classes we are taking, if there's anything else, that you're planning a new case, you see something happening in your college and you want to discuss it, show it to us, maybe we can discuss it in the group as well. So I would want, overall you people to take an interactive you know way towards IR, because this is a totally clinical subject, and it's not about just giving it out to you in terms of diagnostic criterias and images, and then you can later on see. Unless you ask the basics, nobody is going to let you know. So the hardware we'll be discussing, I'll only be discussing primarily the needles for FNAC and the biopsy gun today, and FNAC and biopsy will be covered in today's lecture. We have other non-vascular interventions which we plan to discuss later on, but the primary idea will be to be able to tell you each and everything that you need to do for FNA and biopsy. So the first thing in hardware is your aspiration needle. So if we are looking at FNAC, we basically, what is a fine needle aspiration cytology? So what we do is we take a very thin needle, something like this. I'm not sure if you are able to see it because of the blur. Yeah, now I think you can see it. This is a LP needle. This is a 23 gauge needle. I can open it up for you. Chiba needles are slightly longer. So if you wanted to go deeper, the idea behind Chiba needle is that they are available in longer lengths. This is something around 9 centimeters. So this is a 9 centimeter LP needle, and Chiba needles can go up to 15, 20 centimeters. This is a 23 gauge needle. So the idea behind this is that this is a 23 gauge needle. They're thin needles. Because of it being thin, they are able to, with the suction effect itself, bring in some cells. So what you do is you go into that lesion and you try to puncture it multiple times, 8 to 10 times. You go through the lesion after seeing it in ultrasound guidance, and these needles help in pulling out some cells. These cells are not adequate to run maybe major IHC tests, but this is just to be able to give you a basic diagnosis. They are able to tell whether there's an infection that is going on. You can stain it with gram stain, you can stain it with AFB, or they can give you cells, is an inflammatory process or is it a malignancy. So these are the kind of things you are able to pick up on FNAC. If it's a cystic lesion, you might be able to even withdraw some fluid and give that as well for testing. So basically, these are small needles. This one has a stillet inside. Sometimes, we are able to use we use the, normal needles which come with the uh, syringes. So directly also you can put in, or you can use these which have a stillet inside, which comes out after you have placed it correctly. The difference is, see, don't use a needle directly if you're not sure how much time it will take you to reach the lesion. Say something, there's a large node here. You can directly use a open needle, because the contamination risk is less. Sometimes if you're trying too many times and the needle is open already, then the suction will happen, and even the tissue that you're not looking for will come in that FNAC. But if you're sure that you will go it's very superficial, you can directly use a simple needle. In these needles, till the time you remove the stillet like this, they will not take up any tissue that is there in the system. So we have to use these aspiration needles. Then comes the cutting needles for biopsy. So basically, the idea behind biopsy is that you have to take a bigger piece. So something like a 10 to 20 gauge, depending on the kind of tissue that you're looking for. So say in lymph nodes, we usually use an 18 gauge needle. This is a automatic gun. So you can see here, this is an automatic gun. I'll show you the use and why it is called automatic. And this here is a semi-automatic gun. So both of these help in taking samples, and we'll show you, what is the difference and when something might be more useful. So basically, they are side cutting or end cutting. So the second thing you might want to know about is, one is automatic, second is semi-automatic. I'll show you the difference. And the other thing is side cutting and end cutting. So if you're in the tissue and there is a cut which happens, say like this, on the two, say 10 or 20 whatever is the throw of the lesion, then that's a side cutting thing. But if there is an opening here and you push your needle there and some tissue comes in from the end, then it is called an end cutting needle. So the bone biopsy needles, the ones which are open from the top and you push it in, those are end cutting needles, whereas these normal true cut biopsy needles are nowadays side cutting needles. And you need to be able to decide the length, throw, and gauge of the needle. So length basically means that, this is something around 16 centimeters, 15 to 16 centimeters. It all depends the depth that you are planning to go. Whereas this automatic gun, which is used in breast, is around 10 centimeters, because we're not planning to, kind of go very deep. The other thing is a throw. The throw means, that if I pull this and then if you see this comes out from here. So if we take this off, this is the kind of throw that is going to be there. So you see this is the 2 throw that is there. And I have opened this up right now. Now, when I fire this gun, both the things fire together. So this is the automatic gun. And this, when I pull it off from here, the sample will be there. So it's a side cut thing. You would have this second cannula on top of it, goes over it and cuts a piece of the tissue. So that tissue we can take out, give it in a sample box, go again. We usually take around 3 passes in a biopsy, because we plan to give them for IHC, we plan to give them for various tests. So in malignancy nowadays, there are a lot of markers that they have to run. So giving sufficient tissue in the first go is the right way, because later on you don't want to, you're doing a lung biopsy, you don't want to go back again and do the biopsy again just because we want to run a few more tests. So a 3 good cores, they are usually sufficient. So as I said, coaxial system. So this semi-automatic gun comes with another needle through which it can be passed. So you can put the gun through that coaxial needle. The benefit of that coaxial needle is that once you place it there and you feel that it's not a very easily accessible place, say you're in the lung, you don't want to come out of the lung again and again. Second thing is, you're in the liver, you don't want to puncture the liver capsule again and again. So the first cannula or the first stillet is slightly bigger. You place it at the location, and then this gun can be brought in and brought out. So you can use it, go in, take a sample, bring it out, again give it to the person who's assisting you, and they can put it in the sample box. You again go in, second pass, so that you don't have to reposition everything multiple times. So that is the benefit of having a coaxial system to compare to a simple system. So in this, you just have to go again and again. But if it's a superficial thing, you're not bothered that, it's not very difficult to reach there, you can use this. But most of the times, if I have any doubt and I feel ki, I'll waste my time, I would use a coaxial system. Sometimes we also use these non-coaxial simple systems, because if it's very superficial, even to keep that coaxial needle inside, you will find it difficult. So it keeps falling off. So rather than, struggling with that, you can go in again. So something like a breast lesion, a large supraclavicular lymph node, cervical lymph node, or a, musculoskeletal mass in the arm, forearm, these things you should be, doing with a direct automatic gun. But if it's about, lung biopsy, or it is about liver biopsy, visceral organ biopsy, kidney biopsy, so there are the places that we usually always try to take a coaxial system. because it is just so much easier. And once you have the position in place, you don't have to again and again see in the ultrasound whether I have to do it all the way up, because sometimes there's fat in between. Access is not always easy. You don't want to repeat the imaging over and over again.